Hi, everyone. Getting an epidural for pain management during birth is absolutely a valid choice. Here's what your provider may not be telling you about the difference between epidurals, spinal blocks, and walking epidurals, and how to use these tools in an individualized way that's going to help you have the best experience with them. Epidurals, spinals, and combined spinal epidurals, or CSEs, are three different ways to provide pain relief during labor and birth. They're called regional analgesia because they numb a certain part of your body while keeping you awake. In many other countries in the world, like Netherlands and England, the epidural rate is around 30%. But in the US, the epidural rate is 70%. And there's a lot of different reasons why this is the case. One of the reasons is that the US is one of the only countries in the world that is primarily led by obstetricians when it comes to maternity care. That means that midwives are very rarely seen, and most people go to an obstetrician for maternity care. But in most other countries in the world, midwives provide primary care to most people. And if the person who is pregnant is more high risk and they need to see a surgeon to support them through labor and birth, then they'll be with an OB. Obstetricians are not skilled at normal physiologic birth. They're surgeons and they're skilled at interventions. And many obstetricians today do not even know how to deliver a baby in an upright position, such as standing or hands and knees. They only learned how to deliver babies with the person giving birth on their back, because most of the time when people give birth in the US, they give birth with an epidural on their back. But giving birth with an epidural does not mean you have to be on your back. The model that we see in the US often involves the person giving birth not receiving a lot of individualized support, being told what to do and how to do it. And it's celebrated for the mom to be on their back and to be pushing to the count of 10 and be doing all these things that are so routine, but aren't actually evidence-based. It can take 10 years or more for new research and evidence to make its way into policy. Some very common hospital policies have been completely invalidated by new research and evidence because they came from the 1950s when things were very different back then. Also, from movies and media, women are told that birth is inherently dangerous and painful and terrifying, and getting an epidural is the only way through. Also, in most hospital settings, there is not a lot of labor coping tools available, which makes it really hard to have a normal physiologic birth. The bed is sort of center stage in the room, and there isn't a lot of support with being in the water or using a ball or hanging by a rope or a rebozo. Every hospital and birthing facility is different, but these are just some of the factors that contribute to the high epidural rate in the US. If you do want an epidural, it doesn't mean that you have to all of a sudden submit to other people telling you what to do and you have to listen to what they say. There are a lot of options that you have still, always. And I'm excited to share all of those options with you so that if you choose to have an epidural, you can have an experience that really aligns with your values. Like if you want to birth on your side or in hands and knees, or if you don't want to purple push or do coached pushing, but you'd rather wait till your body starts to spontaneously push, which is called laboring down. Or if you want your partner to catch the baby, or if you want to use the epidural for pain management during labor, but when it comes to birth, you want to turn it off and have feeling and move your body more and catch your own baby. All of this is possible. It's just important to know what the different options are. So let's talk about those. So a needle will be placed in your low back, and that will be used to thread the catheter into your body. The needle will be removed and the catheter will remain in your body, and it can continue to give you medication as needed. You might feel like a bee sting sensation when the needle enters your body, and sometimes you can feel a little bit of tinglies down your legs. Epidurals take about 10 minutes to administer, and then they take another 10 to 20 minutes to become effective. So you stay awake with an epidural, but you can lose your ability to move your legs, meaning your legs can feel really heavy. It's supposed to numb you from the waist down. However, sometimes epidurals are not always effective, which means that it can numb one half of your body, or it can numb the other half of your body, or it can numb like a patch, like a certain area of your body from your belly down, but it doesn't cover the whole thing. It is rare that an epidural doesn't work, but it does happen, which is why I encourage families to learn lots of different labor coping strategies in addition to pain medication. If you're wanting to learn more about labor coping strategies and pain management for labor and all the different ways that you can navigate labor and have a really positive experience, I would love to support you with the Peaceful Birth Academy. And this is where I charge a small monthly fee to access all of my birth and postpartum courses, weekly coaching with me, and a community of other parents. Just click the link below for more information. So these are the different ways that an epidural can be given: continuous infusion, intermittent infusion, or patient-controlled epidural analgesia, or PCEA. With a PCEA, you're able to press a button to administer more, so you have a little bit more control, and it's locked, so you're not able to give yourself too much. So the evidence shows that intermittent boluses and PCEA can lead to less intervention. There's a higher birth satisfaction, less use of forceps and vacuum, shorter labors, and less use of medication. So if you're interested in getting an epidural, you can ask what options are available. Not every hospital will carry all the same options for different kinds of medications for labor and birth. So it's important to ask and learn about the different options available to you. Now let's talk about spinal blocks or walking epidurals. So spinal blocks are a one-time injection of medication directly into the spinal fluid. They work fast, but they wear off quickly. So that means if you go to the hospital and you're like 9 centimeters and you're really wanting an epidural, you could maybe get a spinal block instead of an epidural, because it'll take about a half an hour to get the epidural in place and to get it working. And you may have your baby by then. So instead, you could consider getting a spinal block, which is where they administer just a small amount of medication in one dose to give you a very quick relief experience, knowing that it will wear off in 1 to 2 hours. So a walking epidural is when you combine a spinal block with a regular epidural. And so that means that you're getting the instant relief from the spinal block and the continuous support of the epidural. So this is called a walking epidural. And the reason why is because a lot of people believe that with the walking epidural, or the combined spinal and epidural, you're able to have more movement and do more positions throughout labor and birth. But a Cochrane review found no real difference in a traditional epidural and the combined spinal and epidural when it comes to movement. The idea that you'll be able to walk around with a combined spinal and epidural is actually not true. CSEs are also known to have more side effects like more itching and more fetal heart tone concerns. There's also a new option that is still being studied, and I don't know how widely available it is at the moment, but it's called a dural puncture epidural, or DPE. And what we know about it so far is that it can reduce nausea and the need for extra medication, but it's still being studied. So this involves puncturing the dural matter with a spinal needle while an epidural is in place. So now let's talk about the benefits and the risks of epidurals and spinal blocks. So a 2018 Cochrane review with 11,000 participants found that epidurals provide the most pain relief during labor. They lead to higher satisfaction of pain management. They drastically reduce the need for any additional medication. And they're much safer for babies than injectable opioids like remifentanil, because injectable opioids are associated with much higher side effects than epidurals for babies. They found that epidurals do not increase your cesarean risk or the rate of severe perineal tears, like 3rd and 4th degree tears. Another benefit to epidurals is that if you have a really long labor, the epidural can give you the opportunity to rest and recharge and give yourself the energy that you need to push. But epidurals do come with risks, so let's lay those out next. So in that study, here's what they found. People with epidurals were 11 times more likely to have low blood pressure. They were 3 times more likely to develop a fever, and they're more likely to need a urinary catheter. The need for a urinary catheter can potentially increase the risk for having a bladder infection, which can lead to the need for antibiotics. They are more likely to have a heavy motor block, which means that they can't move their legs at all, and labors were on average 30 to 45 minutes longer. So older studies have linked epidurals to higher risk for forceps and vacuum, but newer studies are actually finding the opposite, that epidurals can decrease the risk for forceps and vacuum, which is probably due to improved techniques with epidurals and lower doses. So other possible side effects are itchy skin, having headaches, feeling sick and drowsy, and sometimes people have more long-lasting side effects like temporary nerve issues or seizures. So let's talk about, if you get an epidural, what does that mean for your birth plan and how you want to deliver your baby? Some people really don't care if they're lying on their back and they're doing the coach pushing and the doctor catches their baby. But the research and evidence we have today shows that your provider being hands-on, meaning they're touching your body and your baby when your baby's coming out, significantly increases your risk for tearing, in addition to episiotomy. So being on your side or even on hands and knees is a much safer way to deliver your baby while protecting your perineum. When you're in a hands and knees position, you're also not putting any pressure or compression on that blood vessel that runs behind your uterus. When you do that, your baby is able to get more oxygen because you're able to get more oxygen, and that can decrease your risk of having an emergency cesarean due to fetal heart tone concerns. You can be in a hands and knees position with most epidurals, and that's because if you lower the bed, the hospital bed, down a little bit and you get on your knees, you can lean over the top with a birth ball or peanut ball or pillows, and you're able to support your body that way. This is a better way to decrease your risk for tearing, to support your baby in getting adequate blood flow during labor, and to also give you more of a sense of agency while you're giving birth. Also, some people want the epidural when they're in labor because they want that pain management for active labor, but they want to be able to push and feel that experience of the baby coming down. So you could turn the epidural off, you could ask for it to be removed, or you could potentially turn the medication dose down depending on what kind of epidural you have. And that could maybe give you some more feeling when you're going through the pushing experience. Then there's also something called laboring down. There's a difference between someone checking your cervix and saying, you're 10 centimeters dilated, it's time to push, and then telling you what to do and how to push while the provider has their hands in your vagina and is like doing these maneuvers to try to get your baby out. Instead, you could be lying on your side in hands and knees, or you could be on your back if you want to. And if someone checked you and said you're 10 centimeters, instead of starting to hold your breath and actively push and having all the people come in the room, you could just wait if your baby is doing well. And this is called laboring down because you could be 10 centimeters dilated, but that doesn't mean your body is ready to start pushing. A lot of the times being 10 centimeters means that the space is wide enough for baby to pass through, but baby still isn't low enough to be passing through yet. Some people with an epidural, especially if it's lower dose, will be able to feel the pressure of baby's head, putting pressure on the inside of the vaginal wall, and that will stimulate the fetal ejection reflex, so they'll start spontaneously pushing. Other people might not have that reflex with an epidural, and that's okay too. Either way, you can still labor down, which means you wait for your uterus to contract to push your baby down lower before you start actively pushing. If you choose to labor down, it could potentially lead to you not getting exhausted super fast. Holding your breath and counting to 10 can be really exhausting, especially if you do it for several hours. And it may not be necessary to do this if your uterus is contracting effectively, sending your baby down even farther. This can also lead to a shorter pushing time, which may be favorable for you if for some reason your pushing phase is a little longer. Some providers have really strict ranges of time that they want you to be pushing for, even if your baby is doing well. So if the clock starts a little later, that may be in your favor. The potential risks associated with laboring down is an increased risk for postpartum hemorrhage, higher risk for uterine infection, and increased risk for neonatal acidemia, which means that babies have too high levels of acid in their blood. It's generally recommended to take an individualized approach on laboring down versus continuing to push actively if you have an epidural. Some providers swear by laboring down and they want to encourage everyone to do it, and other providers feel the opposite. And there are risks and benefits to both sides. If your baby is doing well and was doing well all throughout labor, the risk of your baby having any negative side effect to waiting a little longer is low. But if your baby was showing signs that they weren't tolerating labor well, or if there are any other risk factors at play that may contribute to the need for baby to be born sooner, it may be better to do coached pushing and avoid laboring down. These are questions and conversations you can share with your provider. Thanks so much for listening, and I hope this helps.